Now we have the opportunity to chat with our presenters, go over some videos, and answer your questions. Joining me are our panelists, Dr. Chahal, Dr. Wong, and Dr. Ramchandani. Thank you guys so much for being here. We also have Dr. Wani and Dr. Shah as well. I also wanted to remind our audience members that we have 3 polling questions for you. We will discuss the answers throughout this session. You can find these questions in the polling tab to the right of the Q&A tab. So I'm going to kick things off with just a very short, brief video related to the management of biliary anastomotic strictures. This is something that can be considered in patients with Whipple anatomy or liver patients with a Roux-en-Y hepatico-J. And this is just something in your toolbox to consider. So this will be a brief video and we can start it now. So this is a video from Dr. Shah. So as you can see, the hepatico-J is quite stenotic. We got a wire into the bile duct, but could not fit in any other devices. And so here we were performing a stricturoplasty with a needle knife. After that, a balloon could then fit through the opening and we could use that to further dilate. And you can see that that was effective in opening up this tight stenosis. So again, just a very short snippet to say that this is something that could be considered. There are needle knives which are compatible with both colonoscopy scopes and enteroscopes. Obviously, they have variable lengths and whether the device can go over a wire or not. And I just wanted to sort of circle back and say that this example ties back into our theme today of organ preservation. An untreated or suboptimally treated anastomotic stricture can lead to secondary sclerosing cholangitis changes. So this is something obviously we want to avoid. So I just wanted to sort of now loop in all of our panelists. Dr. Chahal, as our expert on biliary anastomotic strictures, I just wanted to get your input. Is this something that you ever consider in these very tight strictures? Or what do you do when you can't really get much more in other than a wire? Are there things that we should be considering in these cases?
Thank you so much, Dr. Jaloy, and thank you, Dr. Vani and Dr. Shah for having me. I think that, and again, an excellent presentation. So it depends upon the anatomy. In this case, this is an altered anatomy. This is a hepatico-jejunostomy, and this is not an uncommon scenario. It's more common for pancreatico-jejunostomies in patients with Whipple, but we see this in bile duct also. If it's so stenosed where sometimes we're not even able to pass the wire. So that's where, as we discussed in the talk, the option would be biliary rendezvous. If you're able to reach the anastomosis, the end of the afferent limb, and try to get the wire out that way, you can do the entire procedure in an antegrade fashion. But if you're just restraining to the rendezvous, you get the wire. And then once you have the wire through the scope, then you have multiple choices, right? If you were there with colonoscope, as you showed, you can start with a needle knife fistulotomy. If you have an enteroscope, something that you can do, I had a case a couple of days ago. We ran out of the needle knife, which was enteroscope length, but we had a sphincterotome. So you can cut the wire of the sphincterotome and cut the tip of the sphincterotome. So now you have a wire sticking out and you can actually fashion your own needle knife because the opening was so tight, it wouldn't accommodate the sphincterotome. So again, yes, different tools. Once you have the little bit of a fistulotomy, then you can use your 4mm dilating balloon. That's my go-to. And with that, incremental increase to 6 and 8.
Wonderful, super helpful. Mohan, Andy, Sachin, Raj, any other thoughts on this scenario?
I think I agree with Dr. Chahal that we have to innovate. And I think we use a lot of these boogie dilators sometimes to dilate, but unfortunately, we do not use fortunately, we have a shorter length enteroscope, the single balloon. This is a 290 series scope, which can accommodate all the accessories which are available in endoscopy room. We need not to have a longer accessories for this. So if you have a shorter length enteroscope with a therapeutic channel, that makes life much easy in this scenario.
Excellent.
I agree with Dr. Chahal. I think all those things are reasonable. I actually do that technique where we use a lot of long single balloon, and I do cut the end off the sphincterotome. It doesn't always work, but it's nice because the needle can then go in and out, and it's a wire-guided device. For those of you who don't have short double balloon, it's also been described in Japan where at about 100 centimeters, you can cut a hole into the overtube and take your long single balloon scope out and put a gastroscope through. And so then you're limited to 7 French devices, but you can actually do a lot more therapy. I think there's a paper by Professor Itoy about that.
And we had our published experience early on, about 10 years ago, of the technique of stricturoplasty in these patients. And we initially had been utilizing both needle knife and balloon dilation and followed by stenting. And we found that oftentimes we would just remove the stent on the subsequent ERCP, which is a additional hassle to navigate the anatomy. So more recently, as we get good patency with the immediate stricturoplasty with cautery and balloon dilation, then we'll proceed with that without the need for stenting.
Can I ask you guys what you think about using the Sahendra stent retriever? I do that in the pancreas sometimes, and people have described it for tight strictures to bore through. Is there much appetite?
What's everyone's thoughts on that?
Yeah, I've also used that, Andy. I think, it has helped me in a couple tricky situations. And I think another technique, which I didn't mention in my talk, was using the mini probe. You know, if you're down the colonoscope, you don't know where the anastomosis is. It's so pinpoint behind the folds. There was a small series that was out there that showed using a mini probe you can use that to localize anastomosis, especially if the bile duct is a little bit more dilated. It's uncommon to be able to reach that area with the linear echo endoscope, but mini probe can be used, another tool to find the anastomosis if that's a challenge.
Great. I am going to shift gears. We're going to do our first polling question. I'm going to read it out for all of you. Which of the following is false regarding post-liver transplant anastomotic strictures? Option A is a longer duration of stenting has greater technical success at stricture resolution than a shorter duration. Option B is prophylactic antibiotics should be given during ERCP. Option C is there's a high rate of stricture recurrence with balloon dilation alone. And option D is fully covered self-expanding metal stents should not be used. And in this case, answer choice D is false. Fully covered self-expanding metal stents can be used, as Dr. Chahal talked about in her topic, and are equally effective as multiple plastic stents. Anything else you guys want to add here before we move on to another teaching video? Okay, great. We have multiple questions for you, Dr. Chahal, which we'll circle back to after we get through a couple more teaching videos. So if you guys could play Dr. Wong's teaching video, that would be excellent.
Millimeters, and just to get the gastroscope through, but after the dilation, we could pass a duodenoscope. Here you can see a large periampullary diverticulum. Scope position was poor, and usually we teach our fellows to keep the papilla in the top half of the screen. That wasn't possible, so we ended up using a needle knife to change the angle a little bit. Usually cut until I see bile, or if I expose part of the biliary epithelium, then I usually stop and then work on it. Here, I think I've gotten some flash bile, exposed biliary epithelium, switch over to a standard sphincterotome and guide wire. And with a couple of probes, we're able to actually get access into the bile duct. So complex just getting the scope there. We're starting to do a more conventional traction sphincterotomy. Here you could probably take it higher up, even to the kind of duodenum where the diverticulum is, but I started to get some bleeding, and the guy actually is on warfarin. I think he was 86 or 88 and had, I believe, a mechanical valve or something. And so here I thought that this would be actually a good case for large papillary balloon dilation. We dilated to 12 millimeters, and if you can see on the left, there's this expansion where on the right you see the waist, and then on the left you can really see what we're doing. We're basically obliterating any remnants of the sphincter. Here we're sweeping the bile duct, and The stone is just kind of recalcitrant. It doesn't want to come through. I don't think I have control of this video, but probably in a few seconds here, we'll just see the balloon pop through, but the stone remains. So the balloon's, of course, malleable. So now I'm trying wire-guided lithotripsy. The angle was such I didn't think I could freehand a lithotripter in there. And so I think due to the angle and due to some of the soft tissue, even with the prior dilation, I'm not able to get the lithotripter up there. And you can see we're reducing the scope, trying to jiggle it, provide force, and nothing's working. So then I dilate up to 13.5 millimeters and thought that this would do the trick, but it doesn't. The stone ends up getting impacted in the distal duct. Of course, we can kind of push it up if we wanted to, but now I'm kind of, late for my next procedure. I've got the stone in the bottom of the bile duct. And so thoughts are what to do next. So in this instance, I could see the stone, and rather than waste a single operator cholangioscope, which actually doesn't work great in the distal bile duct, in my opinion, I'm using a laser fiber through the sphincterotome, and I can kind of palpate the stone and pull back a little bit. Like I said, you actually don't need a water or saline medium for this. You have to be careful though. There's a plasma bubble that can get up to about 700, 750 Celsius within a millimeter or two. So you want to make sure you're not getting tissue. But we're able to now just basically whittle away at the stone. And the tome is nice because you can bow it very easily, as you'll see as we go along here. So I'm using the tome to palpate the stone. I'm using the device, the laser fiber, and we're basically doing a laser lithotripsy, just kind of using the duodenoscope for imaging. I don't know if we can fast forward slightly, but I do this for a little bit longer, and then we end up, yeah, this is good. So bow up the tome, and you can see we kind of get through the stone there. There's a lot of bile and fluid coming out. And so after a little bit more, and you can see now the stone is moving within the duct pretty freely, we're able to then just put in a retrieval balloon and pull the stone out. And patient did fine. Last I checked, he was 92 years old and doing okay. So the balloon comes through just fine. So I think, it just goes to show sometimes you have to stack these techniques, and sometimes you have to innovate a little bit, but success.
Okay. We can hold on Dr. Mohan's video. Okay. Andy, I'm getting a couple awesome video. I saw both Raj and Sachin start squirming when that laser came out directly onto that stone in an excited way. We're getting a few questions just about how you decided what balloon to use for your dilation, and what type of balloon, whether you do a short biliary CRE or what CRE you like to use. And then the third question I got was, do you prefer to use a duodenoscope to do sort of your duodenal dilations, or do you typically do an EGD scope first and then go to the duodenoscope after?
Sure. The first question I think goes back to the question in the chat. Generally, you don't want to dilate to a balloon size bigger than the proximal duct, because that's a recipe for perforation. And so that's the answer there. The other options are all possible, because if you can get a basket around that's capable of lithotripsy, even though if it's tight, you can still extricate yourself in most situations. And of course, you can use a laser and a metal stent off-label. With respect to, gosh, what was the second part of your?
Sorry, I gave you a 3-part packed question. The second one was, do you use a short biliary CRE balloon? People are asking length CRE balloon use. And then just the third one, not to overload you, is whether you use a duodenal or an upper scope.
You guys can correct me if I'm wrong. We've got some of the greatest ERCP minds here, but the normal over-the-wire biliary balloons top out at about 10 millimeters. So I use over-the-wire dilating balloons like you might for the esophagus or colon. And for large papillary balloon dilation, if you want to approach 20, you usually need one of those, irrespective of vendor. When I'm doing a duodenal dilation, it's oddly enough, usually around 13.5 millimeters, I get a little squeamish because you can start perforating the duodenum, which is tough to repair. But I will often try to use a duodenoscope, and the Japanese have also described a way of doing kind of a poor man's single balloon, where you get the balloon down there and then you kind of pull as you're pushing through, and you can sometimes get through tight strictures in that fashion. In certain cases, I think I used a gastroscope in this one because it was just so tight and I wanted to see if I could get through first. So that's why I used a gastroscope, but you don't need to. And I'll often use contrast before and afterwards just to help define what I'm doing.
Great. Anyone else want to weigh in on any of these things? I have one other question that anyone can answer related to Dr. Wong's talk as well. The question was, sort of what would you do if you had a very tight, and you talked about it a little bit in your talk, but we're just getting some questions on how you would manage a tight distal stricture with a very large stone above it. Sort of what would be your approach to this? Because that's not an uncommon scenario. And anyone can jump in here. I don't mean to pick on you, Andy.
I'm happy to start. I think, graded dilation, you could use plastic stents, pretend it's a transplant stricture over time, or I typically use a fully covered metal stent off label. And then when I bring back the patient, usually stones that are not too big, in the 11 to 12 millimeter range will come out after you take the metal stent out. For bigger stones, of course, this creates kind of a bigger aperture for work. However, if you're going to do stuff like single operator cholangioscopy with EHL or laser, sometimes the hole can be a little big, so you can't maintain fluid. So there's some trade-offs, but I think usually having a larger distal bile duct aperture is beneficial.
Excellent, thank you.
I agree with that, Andy. I think another comment I would like to make is my go-to is also for very tight strictures, put in a fully covered metal stent, but I often leave a plastic stent through them, because sometimes if there's a large stone above it, it can act as a ball valve and it can cause occlusion and risk for cholangitis. Another advantage of leaving a plastic stent through it is, fully covered metal stents, some studies show they can be 80% effective in breaking these stones down. So you won't need an EHL in a subsequent session. And there is a data, I think it was a Japanese study, which looked at 7-French stent. Even single 7-French stent was highly effective in breaking these stones down. So I think, these work both ways, prevent cholangitis and help break the stone down.
Great, all excellent points. I had a month ago 2 stones get stuck in a covered metal stent, and she came back with cholangitis. So I am familiar with that scenario you are speaking about. We talked about it a little bit. Andy answered it, which is awesome. The second polling question, a patient is referred to for a large bile duct stone. That question, as we mentioned, the incorrect answer here is option B, large balloon papillary dilation. And as we've alluded to, that is because we're saying here that the distal duct is 12 millimeters. So you do not want to go beyond the size of the duct because you risk perforation in this scenario. Okay, let us now switch gears. We're going to move on to Dr. Ramchandani's 2 teaching videos. And if we could just play these back to back, and then Dr. Ramchandani, we have a bunch of questions for you.
Yeah. So this is a video to demonstrate a hybrid technique of gallbladder drainage. And you can see here, there are 2 techniques. One is freehand technique, where we use electrocautery enabled stent to be punctured directly, but that sometimes can be tricky, especially in stomach like this. Gallbladder is a mobile structure, and as soon as you puncture that, it may move away. And if you have gallbladder, if a wire inside that act as another anchor there, and you have a plan B if there's a migration, and you can see here the gallbladder is being positioned in such a way that it is brought in very close proximity. And also we have to make sure that we are not dealing with any intervening vessels. And this distance should be preferably less than 1 centimeter, because you are using axial stent, which are usually, they will come with the electrocautery enabled. And you can see here, we are puncturing that after ruling out any intervening vessels. And once you puncture that, then it's better to pass a wire. Though in duodenum, we feel that the hybrid technique may not be that important, but in stomach, it is very, very important. It can serve many purposes. One, we are very much sure that even if there is a migration of the stent, we can have another wire and another fully covered stent can be placed. And you can see here, now we are just releasing the proximal flange over there. And then it is important now to place a plastic stent. If you are dilating, you will remove most of the stones. And the stent which you can choose is also based on how big are the stones. If the largest size of the stones is around 1.5 centimeter, you can use 15 millimeter. And here we saw very small stones, so we choose 10 millimeter stent. Wire was left over there and a plastic stent was placed. The patient is very sick. That's why a plastic, we can stop there for a minute. And this is a different video. Okay, so this is a different video. This is through the duodenum. You can see the duodenum, the gallbladder is more close to the duodenal wall. It is not mobile, and you can use a freehand technique over here. There is no need to use a wire over here. And you can see we are using Spaxa stent, which is not that lumen opposing. It's a large biflange stent with a minimal lumen opposing force. So this can be used in the duodenum also. And as you can see here, there is no wire. It's a completely freehand technique. And this makes the procedure very quick and usually safe in duodenum. So the advantage of using duodenum as a place of puncture is that the stability is there and the proximity to gallbladder wall is there. But you will be targeting the neck, and there is a limited space available in the gallbladder neck for the stent to open, while if you are targeting the stomach, you are targeting the body of gallbladder, and you have ample space available for the stent to open. So there are certain difference between the gallbladder being approached via duodenum or via stomach.
Excellent. Thank you so much for those videos. Those were both very helpful. Can you just walk our audience through a little bit? You spoke about differences between, accessing the gallbladder via the stomach or the duodenum, but when you're choosing your choice of stent, one of the things you mentioned was the size of the stones in the gallbladder, but what are the other considerations you take into account when deciding what approach or technique to use?
Yeah, so if mostly the gallbladder drainage has been described in patients who are not fit for surgery. But there are certain patients, and the data is also accumulating, that even if you do the gallbladder drainage who subsequently become fit for surgery, or an indication where you need to do a conversion of external drainage into internal drainage. So these are the two situations where I will choose a plastic stent, because it has been shown that if plastic stent is used, subsequent surgery becomes not that difficult as compared to a metal stent being used. So this is the one scenario where I'll use plastic stent. Otherwise, I try to not use plastic stent at all, because they are associated with more bile leak and more early blockage of plastic stent, leading to recurrent cholecystitis. Otherwise, I mostly use now lumen opposing stent. Fully covered stent are almost not used, but if the distance between the gut wall and gallbladder is more than 1 centimeter, I still use a fully covered stent, the longer stent. But otherwise, in most of the cases, lamps is being used. And as I told, you can choose the size based on the stone. And also size can be chosen whether you are approaching the stomach, where stomach, if you are approaching, you are aiming the body of the gallbladder and you have a more space available. So you can use a 1.5 centimeter. Duodenum, usually we use 10 millimeter. stent for the transmural drainage.
Excellent. And are you routinely dilating your lambs afterwards, or are you placing them, and if the patient wasn't super sick in this scenario, not placing a plastic and just leaving it as is, or are you dilating after you place it?
Most of the time we are dilating, but if there is a very emergent situation, patient is sick, we just keep a plastic stent along with the metal stent. The plastic stent may also there can be a theoretical reduction of post-procedure bleeding risk, because this stent may impinge on the walls of the gallbladder and may cause some bleeding. So there is no data on that, but a plastic stent within the metal stent may prevent these small bleeding episodes. But yes, blockage bias, Dr. Chahal rightly pointed out, when you are putting a metal stent in a situation where there's a bile duct stone, one has to put a plastic stent to prevent the ball wall action of the stone, which can block the stent. So in such situation, we use here also a plastic stent when we are not dilating.
Great, thank you. Other panelists, do you guys have comments on the videos? I have other questions for Dr. Ramchandani. Go ahead, Andy.
Yeah, Mohan, those are great videos and great presentation, Prableen as well. Mohan, I was wondering, say you have one of these situations where the liver is big or there's not a good window and you have to go through the liver to place the lambs into the gallbladder. Does that bother you? Would you switch to ERCP and try to get through the cystic duct? Or, the radiologists sometimes go through the liver. Would you just do it?
I think I will not try that, because one of the flange has to cross the liver, and there can be a major issue. It's not like, so in that situation, if I'm not getting window, I'll go straight away to the transpapillary drainage. Yes, it is difficult to cannulate cystic duct at times, but if you spend some time and use sometime cholangioscope to find out the cystic duct opening, you still can get through that cystic duct and do a transpapillary drain. And I will not attempt to cross the liver and put a metal stent across the liver. I will prefer to do transcystic drainage.
So I have a couple of comments and a question for Mohan. Great presentation again. So I generally intentionally prefer to go through the duodenum for all the gallbladder drainages. Rarely, because of how gallbladder is situated, you may have to go through the stomach. I personally refrain because of high risk of stent migrations from these, especially if we are doing these for palliative situations. But that being said, I think, as you mentioned, sometimes these patients, they do become surgically fit, and surgeons, they find it easier to fix a hole in the stomach than fixing a hole in the duodenum. So I think, do you generally prefer to go through the stomach route, or you prefer the duodenum route?
I think when there is a severe cholecystitis and then there is a dilated gallbladder, I usually prefer stomach because that's an easy approach. While the duodenum, when the gallbladder is not that distended, and we do not usually find a good window through stomach at that time. And as you said, I definitely prefer duodenum. But if there is a massively distended gallbladder full of pus, usually the gallbladder is attached to the stomach in that situation. And in such situation, I prefer stomach. But as you rightly said, any given choice, if both the situations are easily accessible, I will prefer duodenal approach rather than gastric approach.
Excellent. I was hoping we have another question regarding contraindications, things that you would see and not do EUS guided gallbladder drainage. So can you speak on those a little bit?
I think ascites and coagulopathy are the two very important contraindications of gallbladder drainage in presence of ascites, because you will never be able to, approach the gallbladder through ascites, and there may be a chance that there can be easy dislodgement. So whenever there is ascites, try to do transpapillary drainage. And there is a coagulopathy, again, one need to have a transpapillary drainage, is a better choice as compared to transmural drainage. Otherwise, in most of the other situation, as has been shown in many trials also, that transmural drainage is associated with higher success rate, less recurrent cholecystitis, and also transpapillary drainage associated post-ERCP pancreatitis, which is not seen with transmural drainage. So one can balance on, depend on these situations, can a proper decision can be taken.
I wanted to add that the transpapillary stenting, the technique has been described for many years, and I agree with the comments that technically it is more difficult. You preserve any concern about perforation of the gallbladder. Certainly, we utilize that technique more in patients who are symptomatic cholelithiasis in the liver transplant or pre-liver transplant population, and that is where we prefer transpapillary stenting over gallbladder drainage transmurally. I just would like to add that the luminopposing metal stent is not FDA approved in the United States for gallbladder drainage. It's only FDA approved for pseudocysts and walled-off necrosis. So just something to discuss with our patients prior to considering it is that aspect of it. We just completed the IDE trial, the FDA IDE trial, multi-center study, and that data is being submitted for publication and to the FDA for approval.
Wow.
I was wondering if the panelists can also speak a little bit more about the technical aspects of transpapillary drainage. Mohan, you brought up the idea of potentially using cholangioscopy to get the wire into the cystic duct. Are there any other techniques that you guys use to gain access into the cystic duct?
Yeah. So we use for any cannulation of cystic duct, we go with a short hydrophilic wires, angulated tip. That's, we call them Terimo is most commonly used at our place, and that wire helps us in manipulating the tip commonly. And first of all, what we do is we inflate the balloon by the stone retriever balloon and inject. Sometimes this cystic duct opening fluoroscopically may not be visible if you are just injecting through a sphincterotome. But under pressure, sometime if you inject coming just to the lower end of the bile duct and inflate the balloon, make like a occlusion cholangiogram, and with that pressure you can delineate the cystic duct takeoff. And once you have a cystic duct takeoff available on fluoroscopy, then the life becomes easy. Sometimes because of the inflammation, even after the balloon or occlusion cholangiogram, you are not able to delineate the cystic duct opening. Then the chance of trial and error method comes, and how patient you are to keep on trying and bring on the cholangioscope early. But if you are having a fluoroscopic evidence of cystic duct, then I don't think cholangioscopy is required. You can use this manipulation and get into the cystic duct.
Thank you.
I think another thing was, sometimes you can use the sphincterotome also. That'll help you bow and have the wire, aim in that direction. Sometimes you can use the occlusion balloon and go above the cystic duct opening and block the bile duct, so the wire will preferentially then not go beyond it and try to get into the cystic duct. But I would want to go back a little bit. I think, Mohan, I agree with you about the anticoagulation part, that, if somebody's on anticoagulation, you want to refrain that and ascites. But that being said, most of the times, those are the patients that are referred to us. They are high surgical risk. And what I do is you can tap the ascites before the procedure and make sure you scan the patient every 72 hours and continue to tap the ascites. It does take fistula to heal. And we did publish a small series on US guided gallbladder drainage on patients who are anticoagulation. And since we are puncturing most of the vasculature of gallbladder is posterior wall. That's not we are targeting. We're targeting the anterior wall. So that's where risk of bleeding is much lower, even if the patient is on anticoagulation. And lumen-opposing metal stent does provide a tamponade. So in cholecystitis, cystic duct is so occluded, ERCP, cholangioscopy may not be possible. The duct is edematous, stone blocking, whatnot. But I agree that would be the first route in those patients.
If I might add, I think with about the transpapillary, half the battle is just getting into the cystic duct. But once you get in, there are valves of Heister that are one way that try to prevent you from getting back, and it can be squiggly. So I think leading with a soft angle tip wire is very important, but you have to be careful. I mean, you don't want to use a super stiff wire, but you can actually very easily perforate the cystic duct, and then you've caused even more trouble. So I think if it's going well, but I wouldn't necessarily jam a whole bunch of devices up there to try to, push it if it's really getting very difficult.
Yeah.
Great, thank you guys. I just want to make sure we get to the last polling question. Which of the following is not true about EUS guided, gallbladder drainage? And the answer to this question is C. This answer is false. When compared with transpapillary drainage, EUS guided gallbladder drainage has higher, not lower technical success, and higher, not lower clinical success. So I think we touched upon that a little bit, but I just wanted to make sure for the audience that you guys had these answers. We have one quick additional question that I was hoping Dr. Chahal, you could address. We have a few more minutes and then I'll do a little brief wrap up before lunch. The question is, in a fresh sort of duct to duct anastomosis in a liver patient, you mentioned not doing biliary dilation, which makes sense because of the risk of sort of rupturing this fresh anastomosis. If it's extremely tight, sort of what is your strategy then to get stents across it?
So first of all, I don't think we would encounter an extremely tight stricture in that situation, because extremely tight stricture usually requires fibrosis and ischemia, and that takes time for it to set in. Most of these fresh strictures are pliable. They are not so tight where we are not able to pass our standard occlusion balloon or get a 7 French stent in. That being said, I haven't had any patient where, fresh anastomosis, I was not able to get a 7 French stent in. But you can, if you encounter any such patient, I mean, I would imagine that, you can try, if the wire is going through, try a 5 French stent in that situation, although I can't imagine. Honestly, I've never had somebody where I cannot get 7 in.
Great, super helpful. Thank you. I don't think we have any more audience questions. I think that was the last one. So I'm going to go ahead and wrap up. Thank you guys so much for all of your presentations, participating on this panel discussion.